good for the trial. Thank you very much. Okay, onward we go. Let me introduce my colleague, actually, Professor Jemima Mellerio, who is a pediatric dermatologist and a genetics expert. So she looks after kids and adults who have inherited skin diseases. And I do a bit of that as well, under her supervision, mostly. And we're going to do a sort of chuckle buzz, are we, sort of thing?
To me.
To you?
To you.
To me, to you. Right, okay. So am I starting? To me?
I think you are.
Thank you very much. Very good. So just a warning, we're going to show some clinical pictures because there is no way of disguising the challenge of some of these genetic skin diseases that we have to deal with. These are some of the patients that Gemma and I and our colleagues look after. Michael mentioned them very briefly. We call these genetic skin diseases, so you can inherit these from your mum or your dad or both your parents. Sometimes other members of the family have it, sometimes they don't. We're just going to present between us 7 scenarios to show you the type of work that we do and involve our patients with. So, genetic skin diseases. Number 1, we discover new genes. So we see a lot of patients in clinic with mysterious conditions, and we try and work out what's going on. Here's one. We have recently discovered a new hair gene, slight conflict of interest perhaps, but a new gene. Isn't that an amazing name for a gene? Tuft 1. Complete coincidence, but it's a gene for kids with woolly hair and slightly thin hair as well. And of course, that's the start for improving the management of these particular patients. So gene discovery is one thing we try and do. Solve those mysteries. Scenario number 2 is we use a lot of that information on new genetics to help set up something for the NHS. We run the Rare Skin Disease Laboratory. The National Rare Skin Disease Diagnostic Laboratory is based here at Guy's. So if you're a geneticist, a dermatologist, a pediatrician who's got cases for diagnosis of rare skin disease, it comes to us. We've set up that service and it's now integrated into GSTT and the National Health Service. So that's another direct benefit of changing and improving services for patients that comes out of St. John's Institute. Number 3.
To me.
To you.
So to find better treatments at the end of the day, that's all we want. And it's quite an exciting field to be working in genetic skin diseases when you have cases like this, for example. So this is a girl who had developed progressive pigmentation of her skin and no one really knew why, until the genetic basis was unravelled, which meant that we had an option for treating her. So how did we get her better? How do we improve her pigmentation? Well, this child has a very rare genetic disorder, which means she can't handle vitamin B12 properly. So she has low levels. And over time, that leads to pigmentation in the skin. But by supplementing that vitamin B12, you can see she's had a really good recovery in the pigmentation of her skin. So just an example of how we can use genetic know-how to try and get better treatments for our patients. Number 4, undertaking clinical trials. We've heard a bit about trials today. Trials in rare skin disease are always fraught with difficulties, but they're fantastically important because often there's a lot of money invested in them and we need to know that they're effective and work. And this is one of the things that we've got a good track record of here in London of doing. And two examples here of the kind of work we do. These are both studies that were carried out for epidermolysis bullosa, with this genetic blistering skin disease. So on the left, some gene therapy work, and this is Sue Lewin at the bottom with John, preparing some injections for the patients. What she did here is to take the patient's cells out of their skin, some fibroblasts, and in the laboratory replace the missing gene, in this case the type 7 collagen gene. So to put it in those cells, grow them up, and then inject them back into the patient's skin. And although it's a little tiny area and it's proof of principle, you could produce the missing protein, the type 7 collagen. So this is proof of principle of what we call ex vivo gene therapy. Now on the right, we've got some examples of cell therapy for EB. And this is something we did first of all in children with our paediatric EB centre at Great Ormond Street, and then subsequently in adults here, using cells called mesenchymal stromal cells or stem cells that are given by donors from healthy people, cultured in the laboratory and then delivered intravenously. And although those cells don't survive in the people with EB, they improve wound healing, they reduce pain, they reduce itch, they reduce inflammation, and they make people feel better. So really important work, and this has been built on subsequently now with a very big clinical trial between Birmingham Children's Hospital and Great Ormond Street, looking further at mesenchymal stem cells. This is a busy slide. I think the busyness probably will just highlight to you what a lot there is going on in genetic skin disease research. So on the left, we've got gene therapy, so gene replacement, like I've just explained from Sue's work, of putting in the missing gene. But you can also do clever things like gene editing, so like a little pair of molecular scissors that can snip out the mutated bit of DNA, put the normal DNA in, and recover from the genetic mutation that the person is suffering with, and various ways to deliver that back to the patient. So early stage clinical trials, but very important, exciting work. I talked about the mesenchymal stem cells that release little anti-inflammatory pockets of chemicals to reduce inflammation in patients with cell therapy. But other types of cell therapy have also been tried. So bone marrow transplantation, for example, done in EB and other diseases, and taking healthy cells from donors, for example, fibroblasts, which are important cells in the skin, producing things like type 7 collagen in EB that can be injected into the skin to try and correct the underlying genetic defect. What about protein replacement? Well, actually, you can make proteins in the laboratory in sufficient quantities that you can also deliver that to patients. So it might be injections into the skin, but even better, maybe intravenously as well, and then you've got something that works all over the body, so another important strand. And more what we're seeing is repurposing of other drugs and other approaches. So drugs that, for example, are used in eczema or psoriasis, now being used in genetic skin diseases to overcome some of the problems like pain or itch, wound healing, or fibrosis. So many different strands coming together, and a very exciting time to be involved in genetic skin disease. Number 5, this is important, isn't it? It's what it's about, improving quality of life for patients. So I'm just going to give you an example of this very rare disease. This is a horrible condition called Olmsted syndrome. So individuals who are affected with this have really thick skin on the palms and the soles and on areas of their face. It's impossible to weight bear or to walk or to function normally with feet like this. The pain levels are really upregulated. But through unravelling the genetic basis of this condition, we know that patients have mutations in a gene called TRPV3. And what that does, by having an overacting mutation, it drives a pathway called EGFR. And by driving that pathway, it creates this massive thick skin and it upregulates pain. Now, EGFR inhibitors are a type of drug that are used quite widely in cancer. So could we harness that for these individuals with a very rare disease? Well, yes, we can. And this individual has received a drug called erlotinib, an EGFR inhibitor. And within 24 hours, these patients experience a marked relief from their pain. It's miraculous, nothing short of miraculous. And then over time, the thick skin reduces and it gives people a completely different lease of life. So a rare disease, but an important mechanism. Provide the best possible clinical care. All of these things I've talked about are experimental clinical trials. They are coming, but they're not there yet. What can we do today to improve clinical care for our patients? And again, I'm going to use the example of EB because it affects so many parts of the person who's affected with it. So the skin, the linings of the esophagus, the eyes, contractures on the hands, really many different facets of life are affected by EB. And that's why you need people like this. This is our EB multidisciplinary team. So we've got a large service of 500 patients with EB, and we're based at the Rare Diseases Centre, top left, at the St Thomas's site. And this opened in 2017 for people with EB and other multidisciplinary disorders, where you really need to make the most out of everybody's hospital visit. If you're coming up, you want to see all the specialists that you need to see on the same day. So we can give intravenous infusions, we can do remote consultations when we need to. The rooms are big, so we can have conflabs as a sort of team of doctors, nurses and therapists. We've got all the eye equipment, so we can do eye appointments whilst they're up there at the same time. These lulars in the middle and off to the right-hand side, these are the most important people in our EB team. These are some of our EB nurses. So they go out and support patients, mostly in the community, with home visits, and they're the real linchpins, and much more important than John and I are in the service in supporting our patients. And just to illustrate the kinds of professionals somebody with EB might come across in their path from birth throughout life, all of these people may well play a very important role in the care of these patients. And it's our job to facilitate for that for our patients. To you.
Thank you very much. To me. So you've heard Gemma is a very special doctor, a special dermatologist, and we in genetics think we can see things that other dermatologists can't see. So if I show a picture like this, and I can put up a sentence like underneath that says, what does the dermatologist see? Shall I test? Let's test our residents here today. SPRs? What residents? What do you see? Diagnosis, please. Do you have a diagnosis for these targetoid type lesions on the palms? Oh, there's, so erythema multiforme is the dermatologist, but we see something else, don't we, really? We do. What does the dermatologist geneticist see? We see, that's what you see.
We didn't train him well, did we?
This is what we see. So we see this. This is Palmar hyperlinearity. And that tells us something. That tells us we've got some defect genetically in the skin that affects about 8% of people in Northern Europe. And there's a missing protein called filaggrin, filament aggregating protein. And that deficiency of filaggrin makes you much more susceptible to getting dry skin, to getting eczema, to getting atopic asthma, to getting peanut allergy, to getting all of those things. And you can just see it by looking at the palm. So when we're in clinic, Gemma and I often look at the palm and we go, oh, I see a history of sleepless nights, of scratchy skin, of wheezing. You see, we could set up ourselves in a show, couldn't we, really?
I think we should.
A crystal ball. That's what we could see. We could sit there and see exactly what's going to be happening in the next 10 seconds or so. We could actually probably see a genetics lecture coming to an end. That's genetics, and thank you both very much. Thank you.